You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
Philip Payne is the director of the newly established Institute for Informatics. He's the Robert Terry Professor and Professor of General Medical Sciences and Computing Science and Engineering at Washington University in St. Louis. He earned his doctorate from Columbia University in Biomedical Informatics. Dr. Payne gained international recognition for his research, one, for analyzing data produced in clinical settings, as well as, number two, for translating analyses of biomedical data into usable and useful insights about treatments and improvements in the precision of treatment of patients and their maladies. This recognition led to his recruitment to Washington University and to the establishment of the Institute for Informatics. Welcome to Innovators, Dr. Payne.
Thank you. Very happy to be here today.
You were recruited to Washington University for the purpose of establishing the Institute for Informatics. Why? What is the potential of health and medical informatics, and why at Washington University?
So I think it's a interesting story as to how the Institute for Informatics was created here at Washington University, and I think it's a bit emblematic of what's happening at a national and international level, which has to do with this increasing recognition of the critical role of biomedical and health informatics research and practice across a continuum from basic science discovery to clinical care to population health. In the case of Washington University, there had been a lengthy history of success in biomedical and health informatics research spread across the university for some time. There were very successful groups working in areas such as human genetics, and in particular, the work done in the McDonald Genome Institute.
Yes.
Similarly, there was very important work being done in the Department of Radiology and in the Mallinckrodt Institute for Radiology, focusing on the extraction of features from biomedical imaging. But one of the challenges was that all of these activities were isolated from one another. At academic health centers, it's very easy to create what I often like to describe euphemistically as silos of excellence. And when I was recruited here, it was largely a result of a lengthy strategic planning process in which the leadership of the Washington University School of Medicine and the university writ large recognized that this lack of cohesion was impeding the type of impact that informatics could have across that full spectrum I described earlier. And so I was brought here to build an institute that would bring together those existing faculty in their programs, but also that would recruit new faculty in critical areas that would advance our activities in basic science and clinical research and precision medicine, and train a future workforce of individuals, both practitioners and researchers, that could further develop these types of capabilities locally. So really, my job is to be in part matchmaker to bring together these communities, but also to be an architect to build sort of what a cross-cutting and interdisciplinary informatics program should look like in this modern environment. And so it's very exciting. And then lastly, I would say, why Washington University? In all honesty, I think Washington University, because of its just immense bench strength in the basic sciences, as well as the scale and capabilities that it has in the clinical and population health arenas, is uniquely situated to chart the future course of precision medicine, because we are able to not only discover new knowledge, but we're able to apply it at scale and then study those outcomes both individually and at a population level. And I know of very few academic health centers nationally or throughout the world that truly have all of those pieces that can go from new knowledge to application to outcome and impact. And that's why I came here.
It sounds to me, listening to you talk, that a great number of things had to take place, both inside medicine, but also outside it, to make it possible to even consider pursuing goals like you just described. What took place, and could you help us to figure out roughly when to make this idea of informatics feasible? What are the fundamental building blocks that allow the university to create an institute and establish the bases on which to improve care?
So it's a great question. I think if you take a historical viewpoint, over the last several decades, going back into, frankly, the 1960s and 70s, you've seen this incremental growth in academic programs that really focused on solidifying the science around core methods and theories that help us to make that translational leap from raw data to information to actionable knowledge. And that's really the core premise, right, of biomedical and health informatics as a scientific discipline. And if you, again, take that historical lens, we went from small numbers of individuals that worked at the intersection of the computational and health sciences, coming to realize this opportunity, to the creation of some of the first of their kind academic programs, to the present day where we actually have a robust community of practice of those academic programs. That was really laying the groundwork. I think the second big thing that happened, and it's much more contemporary, was the widespread adoption of electronic health records, combined with the plummeting cost of biomolecular phenotyping, such as exomes and whole genomes. Things that used to be thought of as very unique and special now are rather commodity. In fact, as I like to remind people, in the present day, many of the imaging studies that we order for our patients on a regular basis cost far more than getting an exome or a whole genome for those same patients. So I think the concept of genomic medicine being exceptional is past. The third big sort of driver of sort of the current state of biomedical and health informatics practice has been really just the absolutely exponential growth in computational capabilities that we have. Never before have we had so much computational horsepower at our fingertips, thanks to the advent of cloud computing and other technologies like that, nor have we had the sophistication of artificial intelligence and machine learning tools that we have to help us make sense of these large, complex, and often messy data sets. So I think when you put that all together, you have this sort of evolution in the creation of an academic and scientific base for informatics, and then the widespread adoption of electronic health records, as well as the decreasing cost of biomolecular phenotyping, which is producing data at scale that we've never seen before. And then finally, this evolution of computing. We're at this very unique juncture where we can start asking and answering these critical questions that sort of cut across scales and allow us to really sort of engage in systems thinking, something that we know is essential to improving the quality and cost and outcomes of healthcare at the individual and population levels. The last thing I would say is that I think on the horizon, beyond those sort of drivers I've already spoken about, will absolutely be the widespread use of sensing, mobile, and patient-generated technologies. And quite honestly, we're only starting to scratch the surface of using those technologies. And you can look at it in a positive or negative viewpoint, the positive being it's job security for people like myself. The negative perhaps being that we truly do not know how to use that data in combination with those other data sources we already have in hand. And that is a major challenge as we move forward. So an exciting time, but still a lot of work to do.
Well, just two quick observations. One, it sounds like about 40 to 50 years of a variety of activities and functions going on, all sort of conversing with a great deal of momentum within a relatively short period of time.
I agree. It's sort of one of those, if you're a fan of sort of this turn of phrase, one of those tipping point moments, right?
Oh, yes.
And I think if you look at the history of science, and I'm certainly a bit of a student of history in a more recreational capacity, many of the greatest revolutions in science have happened in this manner, where sort of a slow and incremental sort of building process leads to a critical tipping point, and then an exponential increase in the generation and application of new knowledge. And I think that's exactly what we're seeing in the field of biomedical and health informatics now.
I remember when Richard Rhodes wrote his book about the 20th century, the early part of the 20th century being all about physics. And he said the 21st century will be all about biology and medicine. I think he may be right.
I think you're correct.
You touched on something that I think has had us thinking a great deal. So I know you're aware of and familiar with Dr. Robert Wachter's book, which has the title, The Digital Doctor: Hope, Hype, and Harm at the Dawn of Medicine's Computer Age. Now, as the title suggests, Wachter is cautious, if not downright skeptical about a new era of healthcare in which digitized records, things you've mentioned, very powerful but easy to use, small computers, say your wristwatch or your mobile phone, normal language software, all of that will come together and make it possible for a patient to obtain a sufficient measure of diagnostic expertise to change the nature of the relationship between patient and physicians. So instead of the information being primarily in the heads and hand of the doctor, both the patient and the physician have access, or either possess themselves, reams of information, as well as ways of representing data that can be understood by both of them. That leads me to ask, do you share Walker's concerns? And is this work that takes place in your new institute there a piece of this sort of transformation?
So absolutely. So I would begin, I might recast sort of that caution that is more sort of appropriately sort of cautious optimism. Because I think, in the digital doctor, the story that's being painted is that we are at the precipice, as you and I were just speaking about, of a major change in healthcare. In which these digital health tools at the patient and provider and population levels will fundamentally reshape the way in which we educate providers, the way in which providers and patients interact, and the way that we evaluate outcomes over time of healthcare delivery. Especially as you imagine a world in which we move away from sick care, the current transactional system that we have, and towards one in which we really focus on wellness, right? Yep. And I think when you put that all together, it's both a very exciting time, but a time in which we have to be very thoughtful about how these technologies come together and how we make sure we're preparing all of the key stakeholders in the community to be able to use them appropriately and responsibly. And I think, in the digital doctor in particular, what you see is sort of the reflections of an individual who's had great experience in both the delivery of clinical medicine as well as the training of future physicians, describing the critical questions that we must ask and answer. And I think part of that comes from the fact that we can't necessarily have unbridled enthusiasm and say every new technology is going to fundamentally reshape medicine, because the stakes in medicine are very different than if I'm building a new website to help people purchase an airline ticket or, make a hotel or restaurant reservation or identify their next new car. The stakes in medicine when we use these technologies are literally the health and wellness of human beings and populations, which means the sort of bar by which we judge the success of these technologies and our success in preparing people to use them appropriately has to be commensurate with those stakes. And I think that's the take-home message. It's also why it's so important for us to understand this cross-cutting role of biomedical and health informatics in the health and life sciences community. It is an integral part of how we're going to train future researchers and clinicians and leaders. It's a critical part of how we make decisions at a strategic level about what technologies we use and in what capacities within our delivery systems. And it's a critical driver of how we think about policy making that influence what's paid for and what's not, what represents high value or low value care, and what sort of responsibilities we place on all the individuals involved in this very complex environment. And it's important to note that, informaticians, they're not just computer scientists working in medicine. They're also trained in the social and behavioral and cognitive sciences, as well as in sort of the core driving problems that truly sort of define the practice of medicine, as well as biomedical research and population level health. And, being those sort of human translators that can sit at that intersection point uniquely positions biomedical and health informatics leaders and practitioners to sort of translate between all the parties required to sort of answer all the questions that I just outlined in sort of that laundry list, if you would.
Let me follow up on that, just on one key point. Is the profession of medicine ready for the kind of engagement you're talking about, where the patient will have a great deal of information, maybe not as much as the physician herself, but is the medical profession ready for a world in which, to use a sort of steal a line from somebody, the patient is in and the doctor can see them? Is that still something to come, on a realization that the relationship between physicians and patients may have changed?
So I think it's a very important question. I would say that we are in the very early days of preparing both providers and patients to be able to not only survive but thrive in this new environment in which the information required to make intelligent decisions about both wellness promotion as well as the treatment of disease will be distributed across multiple individuals. Providers will have critical information, patients will have critical information, other caregivers, family members, community members may have pertinent information. And it will no longer be the case that just the physician will be in possession of all of those information assets at the point at which a decision needs to be made. So that means we have to train our clinicians and other care providers to be able to understand that role and to appropriately manage all of those information streams, because increasingly we are asking clinicians to be information managers. Simultaneously, we are going to have to educate patients to be engaged, active, and sort of situated consumers of health information. And I think one of our biggest challenges there is health literacy, as well as sort of the ability for people to differentiate what are high quality and trustworthy information resources and which are not. And then finally, you know, all of the other actors, what are their roles? What information do they have, and what value does it bring to the table? So that means we're going to have to look at how we train physicians and other care providers in a professional setting. We're going to have to think about how we increase health literacy and sort of critical information seeking knowledge on the part of patients. How do we incentivize their active engagement? And then how do we understand who else needs to be at the table? You know, one of my good colleagues once said, and I think it's a very fair statement, everybody in the healthcare system, by and large, is subject to tremendous amounts of training, and there are high degrees of accountability associated with their roles, except for one critical group, which are the patients themselves.
True.
Do not train our patients to be active, engaged, and well-educated consumers of healthcare. There certainly are active and engaged and well-educated patients who have decided to do so of their own volition, but it's not part of the system, nor is there accountability. And you can imagine a world in which wellness promotion is incentivized. We will care a lot about what patients do when they're not in the hospital or in the clinic, but where they live, work, and play. And part of that means giving them the tools to be successful in living healthy lives, but also making sure that there's appropriate accountability, like everyone else in the healthcare system, to make sure that that model actually works.
That's a great point. That leads me to turn away from the patient-physician relationship and more to how you view the field of informatics affecting, let's just say new medications, devices, and protocols in clinical studies and trials. Is informatics going to play a significant role in exploring new protocols and the like?
So I think absolutely. I'll use a concrete example, which is the discovery of new drugs. So we certainly know that the drug discovery pipeline that we presently have is largely broken. If you were to plot any of these sort of curves that show cost versus successfully approved new medications versus the failures of drugs that either did not work in the lab or in an early stage clinical trial, all of those plots will be moving in directions that we would mutually agree upon as being less than ideal, perhaps even catastrophic. So when you have a situation in which the average new drug can take upwards of 15 years from discovery to widespread clinical use, and that may cost close to $1 billion, you quickly realize that we need a different approach. So in the case of drug discovery, we have clear evidence that in a variety of disease states, using computational methods that have been developed by informaticians, we can identify new uses for existing drugs to treat those diseases. Case in point, in my own laboratory, we've done work focusing on melanoma. And in melanoma, we have some very effective frontline therapies, but we also have a group of patients, sometimes upwards of 30% of patients, who within a relatively short time frame after treatment with those frontline therapies will become resistant to those drugs. They will no longer be effective for them. And so we've asked the question, is there a way to prevent that resistance so those frontline therapies work better longer? And we've done that by mining large amounts of publicly available genomic data, identifying a unique genomic signature that correlates with the onset of resistance, and then also mining large volumes of data that correlate with drugs and their targets that have been previously studied in any number of disease states during rigorous clinical trials. And we've actually found existing drugs that have been developed and studied in non-cancer use cases that clearly target the genes and gene products that are implicated in that genomic signature for resistance. And we've taken that all the way from computational discovery to early stage evaluation in both laboratory and animal models, and have shown success.
Amazing.
The difference when I compare it to that 15 years and $1 billion for traditional drug discovery is that new combination therapy using an existing FDA-approved drug took us a little bit more than a year to identify and cost about $50,000.
Oh, wow.
Right?
Yeah.
1 year and $50,000
absolutely
as opposed to 15 years and $1 billion. Clearly not going to work for every disease state.
Agreed.
It points to the power of these computational approaches to accelerate discovery science and to rethink sort of the hypothesis generation and testing paradigm. And we're exploring this in other diseases, everything from liver cancer to rare genetic diseases to now we're looking at how this might apply in a variety of other sort of situations that are frankly not cancer related. So I share that with you because I think it's an exciting time to rethink the discovery paradigm, but it also requires very rigorous approaches to applying these types of methods, which again, informaticians are uniquely trained to do.
And I can't help but just comment on the fact that the idea of going back and taking a drug that had some measure of effectiveness and then looking at its application perhaps in another context just strikes me as such a wonderful opportunity to build on science, as all of us were taught to do, is we don't toss away what's known and we try to build on it. And it strikes me as a perfect example of that.
Well, and I think you touched on an important issue, which is that, if you create an environment in which you engage in really what I would describe as open science principles, in which we share data sets, we share findings in a way that are actionable and that they can be built upon in sort of an incremental way, we turn science into something that becomes cumulative in its impact rather than episodic. Now, there's a lot of work to be done to make that possible. Quite honestly, in the health and life sciences, the sharing of data, the sharing of findings is not always as democratic and liquid as we would like. But informaticians are working on that problem as well. We are building tools and platforms to allow people to safely and responsibly share their data, share the code that they use to analyze that data, share both negative and positive results, and get appropriate academic credit for it, while also making it possible for sort of this cumulative approach to discovery to become more commonplace and more accessible. And I think that's an exciting opportunity for us, but it's also a function of not only a technical challenge, but also culture change.
Exactly. That's what I was going to say.
Yeah, and I'll go back to that unique training that informaticians have. That extends beyond technology and computation, but also includes social and behavioral sciences. Studying the adoption and optimal use of these types of methods from a human factors and from a workflow and a policy standpoint. And I think that's equally important as we think about how to make science more impactful, more timely, more cost-effective.
And the fact that you're willing to take a look at what I would like to call psychological and sociological aspects of healthcare and medicine, that seems to me to be of great wisdom, because again, if we come up with new techniques, but we do not have a shift in cultural values, it's not likely people are going to change their behavior very much. So it sounds like informatics has at least the potential of breaking that barrier too. Let me turn to a very different one and put you a little bit on the spot. I know you've not been at St. Louis very long, but when we were preparing for this interview, we went out and looked at where Washington University's home is. That's St. Louis. And when we took a look at health status and health disparities in the region in a study that was reported back that covered the period of 2000 to 2010, here are some of the findings. They said there were substantial drops in deaths attributable to leading chronic health conditions, encouraging. Significant change in age, poverty, and racial ethnic composition. And notwithstanding improvements over the decade, persistent race and gender-based disparities. Now, the report refers to social determinants as the factors in the health status of the region. But those relationships are not spelled out in that report, and to my knowledge, not many other places. And so it may very well be that those relationships are more a function of correlation than causation. So as you think about what your institute is going to be capable of doing, is it realistic to think about identifying causes of health status and disparities in different populations using informatics?
So absolutely, I'm glad you sort of made reference to that report. And I think in many ways, St. Louis is sort of an intense microcosm of the challenges that our national health system has. Practically speaking, we have tremendous disparity and access issues within the St. Louis region in terms of the ability of individuals from a variety of backgrounds and socioeconomic statuses to gain access to appropriate health care when they need it, where they need it, in a way that is appropriate. And I think that's quite worrisome, because I think it speaks to the sort of fractured nature of our healthcare delivery system, but it also speaks to, quite honestly, our lack of understanding of how social determinants actually impact in communities. Now, some of these factors, frankly, are magnified in St. Louis, perhaps compared to other cities, but nonetheless, I think they exist in a pretty pervasive way across the country. When we talk about social determinants as a specific example of this problem space, we know both anecdotally and from smaller scale studies that there are a variety of social, economic, and demographic factors that influence the ways in which people perceive healthcare, how they choose to access it, and frankly, whether or not the appropriate healthcare is available in the neighborhood settings where they are situated. We are prone to say here at WashU and with our colleagues at BJC Healthcare that the simplest form of precision medicine is just making sure that the right provider is in the right place at the right time. We don't need to sequence a patient. We don't need to use expensive technologies. We simply need to understand need and make sure the right providers are there when people must access healthcare. Now, the other reality around social determinants is that in those smaller studies that I was making reference to, we actually have come to understand that social determinants, like I said, race, ethnicity, social, economic background, access to healthcare, actually far outweigh the influence of anything that we know about the genome right now in terms of their impact on healthcare outcomes. So think about that. Many of the major research initiatives that we speak about at a national level are focused on how do we get more clinical data and more genomic data, because we believe that is the future of healthcare. And I do believe that understanding the genome and making it actionable will be a critical facet of the future of healthcare. But if we truly wanted to focus on data that was going to make a difference in the lives of the patients that we serve, like the patients here in St. Louis, we would focus far more on social determinants. The challenge is, how do you collect it at an appropriate level of granularity? How do you make sense of it? And how do you connect that perhaps with the data that we have within the healthcare delivery system? And one has to be quite thoughtful about this, because in fact, there are critical cultural and policy and perceptual issues that have to be tackled. And one of the first that I always remind everyone is, before we go out into the community and start talking about the studies that we want to do as academicians or investigators in healthcare, I think it's incumbent upon us to talk to community members and understand what are the problems that are important to them. And I don't know that we always train people to know how to do that. So within the Institute here, we have established a group exclusively focused on population health informatics. And we use that term very specifically because we're not just interested in measuring these types of phenomena, we're also interested in using data to intervene in those communities and make changes that improve healthcare access and outcomes. So it's more than just a unidirectional measurement exercise, but rather engaging with the community, understanding their needs, understanding these drivers of access and disparity and variable outcomes, collecting data, working with community members, integrating that with what we have within our healthcare delivery system, and then making smart decisions about how we might change access or other delivery paradigms. And we're just starting to do that. One of the great examples is we have a project working with our Institute for Public Health and a variety of partners throughout the St. Louis region to create a public health dashboard, looking at various aggregate data that tells us from a social, economic, and geographic standpoint what types of variances we see in things such as the outcomes of violent crime or STD rates or access to even primary care in sort of chronic disease conditions that have a high burden, such as cardiovascular disease or other sort of similar disease states, say metabolic syndrome or type 2 diabetes.
Yes.
And we're doing that in a way that we want to mobilize that information so that rather than having it siloed with individual government agencies, community agencies, or healthcare delivery systems, we're making it available on demand and visualizing it so that people can make smart decisions. Should we open a new clinic? Should we condition certain care providers? Do we need to do more outreach and engagement to make sure people are following up with their providers after they go to one of our emergency rooms? These are the types of questions that we need to be asking and answering, and we're certainly invested in doing that through our organization.
Well, I know we're running out of time, so I'll close with a brief anecdote, which I think is now myth. Back in the late 1950s, there was a public health worker who got very interested in, I believe it was Guatemala, and they were having soaring birth rates and high morbidity rates among mothers and infants. And so they decided they needed to address the question by bringing birth control measures. So they brought with them huge numbers of condoms, and they distributed them and, of course, gave them instructions in Spanish to read them. And they went away, came back about 2 years later. The birth rates were still soaring, but it didn't seem to matter because the caloric intake of everybody had gone up considerably. And so the question was, well, what made this possible? They clearly used all of these condoms, but it hasn't stopped babies from being born, and yet the babies are being fed. And as it turned out, they used the condoms, the individuals in these mountain villages used the condoms to store seed from one year to another so their crops would be better. Didn't cause anybody to not have a baby, but it sure did feed them well. The point I guess I'm trying to get to is understanding these social determinants clearly is of a very complex nature. And I suspect that the Institute for Informatics at Washington University is probably going to be a leader in doing so. I'm convinced. Thank you very much for your time, sir, and keep the good work going. We'll talk again.
All right, thank you.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.